Welcome to this very exciting video all about this amazing multi-center database run by trainees. My name is Joel Dunning and I'm here with CTSNet with 4 amazing and whizzy trainees from the UK are going to tell us all about this. We've got Luke Rogers, a Cardiothoracic Surgery Registrar from the southwest of England, and he also co-runs a group called the Cardiothoracic Interdisciplinary Research Network. He's joined with Akshay Patel, who is a cardiothoracic surgeon and registrar in the West Midlands. He's doing a PhD. He's got the brain the size of a planet, and he's also a thoracic surgeon, and he leads the thoracic part. And then we're very lucky to have Ruth Benson. She's an academic clinical lecturer and a vascular surgery registrar. She leads the vascular surgery arm, but she's also really intimately involved with this CovidSurg database. So first I'm going to come to you, Ruth. This database is amazing. 24 countries, over 1,000 patients who've had surgery and have got coronavirus. It's published in the Lancet. It's got 4 publications. I mean, truly amazing. So maybe Ruth, if you could just give us a bit of a rundown about what it's all about, the kind of patients and the project as a whole.
Yeah, thanks for having me. I mean, it's a very simple premise. So the team set out to look at any patient having an operation who ended up with a positive swab either before their operation or within the 30 days afterwards. And they looked at 30-day mortality. So the original idea was as simple as that. But they're used to working globally with international teams. And that's exactly what they did. So they developed a very simple and clear initial question, and it's grown into what you've seen, what you can see now, into a huge impact in a Lancet publication.
And this is mainly trainees, is it right? And it can also be retrospective. So people looking right now, watching this video, you could get involved and start contributing and be a co-author. Is that right?
Yeah. Absolutely. So originally, the Global Surge team started off as a trainee research network. It's built up more, so you do need to have a consultant PI at whatever centre you start recruiting patients from, but you can look at it retrospectively. Most centres in the UK have registered it as an audit, so you do have to register it in your centre in whatever way is deemed appropriate. But yes, you can get involved from now, and then you can look retrospectively at the patients that you've operated on over the past few months.
Fantastic. Well, we're going to come back so you can hear some of those amazing results. But let's move over to Luke. Luke, first of all, tell us a bit about your research network that you run in the UK, and tell us how you've linked with Ruth and the CovidSurg database to add cardiac surgical patients.
Yeah, so the Cardiothoracic Interdisciplinary Research Network is a trainee research collaborative that was set up in the UK and Ireland around 2018. It's a group of multidisciplinary healthcare professionals that are interested in being involved in high quality cardiac and thoracic surgery research with the ultimate premise of improving patient care. I saw the idea of the CovidSurg collaborative sort of early March time on their Twitter thread, and basically saw this as an unmissable opportunity to galvanise the collaborative cardiothoracic surgery research network across the globe. The CovidSurg collaborative done some fantastic work laying the groundworks for these studies in an astonishingly small amount of time. And I thought it would be an excellent opportunity for both the cardiac and thoracic specialties to get involved, to group together across the globe, and hopefully with the aim of producing some subspeciality papers which can look at the impact of COVID-19 on cardiac patients specifically, and also on thoracic patients specifically. And we'll cover that a little bit later on. But the general premise and idea is that there's this collaborative of collaboratives, and the fact that we can work with our surgical colleagues across any country now, thanks to the internet and Twitter and Wi-Fi, means that this was it's just an excellent opportunity to sort of build something that going forward could do so much more.
So just from the very specifics, you're doing the cardiac surgery patients. What do you exactly do to take part and to get patients into this database? How easy is it? How difficult is it?
It's really straightforward. So as we've already touched on, the CovidSurg Cohort study is a global observational multi-centered study. It looks at SARS coronavirus 2 infection in all patients and in all patients having surgery. And that's not just specific to cardiac, but in relation to cardiac, it involves identifying those patients either 7 days before they have their operation and following them up for up to 30 days after their operation, so that we pick up infections that are picked up within the hospital setting. All that's required from the initial PIs and the centres, as Ruth has already mentioned, is it needs registration in the local centre and on the CovidSurg website, with the links which will be provided with this video. And then you basically have to locally collect the patients that are having their infections and upload their data to a REDCap electronic database, which is all anonymised. And then the data results in some fantastic work. As we've already seen and mentioned, the Lancet publication was over 1,000 patients, over 200 hospitals across the globe, although there is currently a focus in the UK and in North America. We're very keen to try and increase the centres in India and also in South America, where the coronavirus currently seems to be having the most impact on those countries. But it's really straightforward. It's all retrospective, and there's no excuse for anybody not to get involved because it's as easy as.
Yeah, fantastic. Yeah, we've been doing it in our hospital. Yeah, you can just look back at the patient. They do have to have had coronavirus. That's the important thing, isn't it? So they've had heart surgery, they've had coronavirus. Yeah.
So for the CovidSurg Cohort study, they have to be coronavirus positive, and that's on a lab test. Although in situations and centres where that isn't possible, you can do it on a clinical diagnosis and also on CT diagnosis. However, if they then subsequently do have a lab test, if that was to come back as negative, those patients would then subsequently be excluded. But all that is required on the REDCap database is for that data to be uploaded, and the central committee are very good at then picking out what's happened with the patients in the follow-up.
Fantastic. Let's move to Akshay. So Akshay, you're a thoracic surgeon working on the thoracic surgery database. Now this is quite different, isn't it? This is anybody having a cancer operation, whether they've got coronavirus or not. Maybe you could explain a little bit about what's different about this different study.
Yeah, absolutely. So as Luke talked about CovidSurg, so CovidSurg cancer is almost like a sub-study that's looking at it's an observational cohort study that aims to seek variations in routine care for patients who are presenting to cancer services with potentially resectable malignancies. So it's assessing the safety of surgery and the feasibility of surgery, but more than that, it's also looking at the impact of the changes in routine diagnostic and treatment services for these cancer patients. From a thoracic surgery specific point of view, as an example, let's say, so 2 cohorts of patients that have been included are patients who have undergone curative resection for lung cancer already in the COVID-19 environment. And then there's a sort of another cohort of patients who have been planned for curative surgical resection as part of the MDT process, but have had their treatment, their definitive surgical treatment either delayed, postponed, or perhaps even changed to something, let's say, less optimal for safer radiotherapy or chemotherapy in light of the current climate. And I think the second cohort is quite important to appreciate, because we know from a lung cancer point of view, stage 1 lung cancer, for example, time to treatment greater than 8 weeks leads to significantly decreased rates of 5-year overall survival. So it's really about assessing safety and efficacy of surgery, but more than that, it's also looking at the variation in routine care from a diagnostic and treatment point of view for these cancer patients and how that affects them down the line.
Yeah, fantastic. So very different, but still can be done by a trainee and can still be done retrospectively. So yeah, in our hospital, we've gone back through all our MDT records and we put in all these people we sent to radiotherapy instead of surgery. So, but in terms of like Luke, it was quite easy, retrospective. It was just a database. How have you found entering data? And also, I guess they can be in both databases, can't they?
Yeah, absolutely. So any patient who is entered in the data, they can be entered into CovidSurg and CovidSurg cancer. As you've correctly said, the studies can be retrospective. So particularly from trying to recruit participants in the international and even national arenas, trying to tell them that because the studies can be retrospective, it has facilitated recruitment because patients can be put into these databases from the beginning of when the impact of the pandemic initially struck. Doesn't have to be done sort of contemporaneously or even in line with where you are in the timeline, which has been useful.
Yep. So Ruth, let's move back to you. The really amazing results you're getting out of this. So firstly, you've got all your names on the co-authorship list. So it's all going to be PubMed index that you can say you've had a Lancet publication. So what a great stimulus to get involved. But Ruth, maybe talk about the Lancet publication, what you've published so far.
So the Lancet publication was looking at the first cohort, really, and there were thousands of patients in there, all across the board. So not just cardiothoracic, but across all specialties, across all hospitals. As Luke said, very specifically, they had confirmed COVID-19 diagnoses, and looking at the 30-day post-operative mortality, I think everybody could agree that the results are a little concerning. Certainly a strong percentage of patients. We're looking at strong 30-day mortality, so we're looking about 24%. So about 250, just over 250 of 1,200 patients were looking at an overall mortality, and that was major and minor operations as well. They also focused on pulmonary complications, and 50% of patients with a positive test, remember positive test, even if they hadn't had any symptoms, 50% of those patients then developed post-operative pulmonary complications. So a huge number. And of those that specifically developed post-operative pulmonary complications, the 30-day mortality rose to nearly 40%. So, and that was the majority of death. So it was in a very clear, succinct message saying that COVID-19 is dangerous for our surgical patients. Just having it puts you at an increased risk of developing those pulmonary complications. And if you get pulmonary complications linked to COVID-19, then you're really, really high risk of not making it out of hospital. So a really strong, clear message.
Yeah, I mean, phenomenal and scary. And then I suppose out of the cardiothoracic patients, there's about 50 cardiac, and there's sort of 40 or so thoracic. Again, there's 30% death in the cardiac group and 42% death in the thoracic group. I mean, this is phenomenal, scary stuff, but so important for decision making in areas where maybe you haven't got your coronavirus under control.
I think a really strong incentive for the cardiothoracic team to develop their own independent stream so that the global cardiothoracic community can come together with their own patients to get even greater N number so that you can really nail down the message for your own patients and counsel them, individually on a really bespoke basis.
Yeah, well, fantastic work. So if I just move to Luke, who is a co-chair of this Interdisciplinary Research Network, what do you think the future should be for the cardiac and thoracic patients? What do you want to happen over the next few weeks for this database?
So ideally, we want every centre, certainly in the UK and Ireland and North America, that is still performing cardiac surgery and thoracic surgery to be included in both of these databases where possible. There is absolutely no reason that then also every patient that has COVID-19 and is having surgical procedures across the globe can't be included in CovidSurg Cohort. What the UK was quite quick in doing was basically stopping all elective surgery, particularly in cardiac and thoracics. And that's meant that our numbers of cases, of positive cases that we've operated on has been relatively small. We know that across the globe, that isn't always the case, or hasn't been the case in some situations. And therefore, rather than that information and that data be kept locally and regionally, it'd be much more helpful for the information to be shared amongst all the cardiothoracic community and the global community, to be able to actually delineate the impact that this infection is having on our surgical patients. Because as the Lancet paper illustrates, it's quite a stark increase in risk for those patients undergoing elective surgery. And on the flip side of that, there are always the emergency operations, which we then need to be thinking about how this impacts on our prognostic planning for these operations, and also probably increasing the threshold of maybe sometimes not pushing forward surgery as the most appropriate plan in some cases. We're all, this is a very novel disease that everybody's sort of catching up with, really. And the more that we can actually share this information across the globe and across the centres that are doing things slightly differently, the more they're likely to learn, and then the better able we're going to be able to plan this going forward. And most pertinently for the UK actually now is that we're probably going to find that as we relieve the lockdown and start going back towards normal activities, that we're going to start seeing our cases of COVID positive operations increase again slightly, and how we manage that and what the best way of doing that for patients going forward is.
Fantastic. Yeah, really exciting database to add in, and we'll learn a huge amount, especially as you say, those dissections and the people you can't delay, like a COVID positive patient having a dissection. What is the best treatment? Hopefully your database will help that. And then just finally turning to Akshay, you've got a really interesting database here of patients who've had thoracic surgery, but actually the ones that don't have thoracic surgery, who go and have radiotherapy when they would always have had an operation, or they have delay to their surgery. I mean, this is going to be a fantastic database if we get the numbers up. So how do you see the thoracic side of this panning out, and what results do you think we'll find?
Well, I think so far we've sort of, talking more broadly, over all the specialties, have collected over 20,000 cases. Over 1,000 of those are thoracic cancers, of which 43 were COVID positive, plus additional cases that were COVID positive in the thoracic benign cohort. I think through further collaboration and participation from international groups, we're hoping that number will increase so we can get a much better global representation of how cancers, and particularly thoracic cancers, have been affected. As has been alluded to by Ruth and Luke, COVID-19 it's a universal problem. It affects everybody. And to make the sort of data as meaningful as possible, to make the messages that are conveyed from that data as meaningful as possible, participation in the global arena is going to be needed to make it as representative as possible. And I think from the cancer point of view, that's especially important, because we've seen in the UK, there are patients that we're seeing on a regional and also on a national level that are being deferred for suboptimal treatments, let's say. Whether that's true of other countries, we don't know yet, but hopefully we'll come to find out. And I think sort of the final thing to say just about that really is lots of high impact publications have been produced from the data set so far. I think going forward, I envisage more publications of a high impact nature to be produced, and with further participation, with further collaboration from more units. And given the corporate and the collaborative authorship model, there's no reason why we can't build on what we've already achieved in terms of data accrual. Yeah. I think just lastly...
Fantastic.
So I was just going to add as a few sort of closing remarks. COVID-19 is affecting us all. The fantastic work that the CovidSurg studies have put together is providing a means of quantifying the impact that this is having on surgical patients across the globe. We have a fantastic opportunity within Cardiothoracic Surgery here to collaborate with the CovidSurg team to get this information across and to benefit patients across the globe. It's also a fantastic opportunity looking beyond COVID, if people can do that, to catalyse trainee-led international collaboration in cardiothoracic surgery. And there is absolutely no reason now why multi-centre, multinational cardiac surgery thoracic trials can be being delivered. And I think that'd be a silver lining to come out of this pandemic, if that's something that we can all step forward towards.
Yeah, absolutely. Well, you three are doing an amazing job, and this is a stunning global collaborative. I certainly encourage everybody to get involved. So I've just put a little summary on the screen here, how people can get involved. So if you just want to have a little look at this, it's globalsurge.org/CovidSurg. Just have a little look, see what you think. And then if you want to get involved and become a submitter, then you can register your interest. I really would direct you to the Lancet publication. Look right down the bottom and you'll get your name as one of the co-authors of the next papers. And that just means, you have to put 30 or 40 patients in. And then, as Luke and Akshay have said, cardiothoracic research could take a new direction. If we can do international big cohort studies of this, we can do it in all sorts of other things. So Ruth, Akshay and Luke, thank you very much for coming on. Well done for your hard work. I think we're going to see a lot more papers besides this coming out, and they really are phenomenal results. And once we get to a couple of hundred patients in each of the cardiac and thoracic ones, we're going to learn so many things. So from myself, Joel Dunning at CTSNet, and everyone here, just well done with everything. I hope everyone gets involved, and congratulations.